The following podcast is part of a certified educational activity titled New Concepts in Prostate Cancer Care: What Oncologists Need to Know to Optimize Patient Outcomes. Access the entire activity and complete the post-test at peerview.com/NXS860. Downloadable slides and practice aids are also available.
So good evening and welcome to our conversation about evolution in prostate cancer. I'm Rob Dreiser from the University of Virginia. I am joined this evening by three distinguished colleagues: Dr. Evan Yu from the University of Washington, Dr. Phil Kantoff, Chair of Medicine at Memorial Sloan Kettering, and Chuck Ryan, who is the Division Chief of Hematology, Oncology, and Transplant at the University of Minnesota. But let me start by talking about the early sort of PSA era. There are a lot of young people in the audience, and Dr. Kantoff and I are not young, and we actually started our clinical training and practice in the pre-PSA era. So PSA, prostate-specific antigen.
You did, not me.
Yeah, that's what he says. Yeah. So PSA, patient-specific anxiety, patient-specific anguish, patient spouse is angry at you. All of those things. Everybody has one, right? So PSA has been around for a long time. But prior to PSA, that era consisted of a couple of sort of notable things. So as physicians, we carried pagers that were this big in the snow to work. But the other thing that happened is that occasionally that pager went off when you were driving somewhere and you had to stop and find a phone booth. And for those of you young people, a phone booth is a big glass house. There was a phone in it, and you had to put coins in it to make it work, and you talked, okay? So that was the era of pre-PSA. So prostate cancer patients presented about 10 to 15% of time with metastatic disease. So Denovo presentation, right? Because nobody knew they had prostate cancer. The most common operation in the United States was a transurethral resection of prostate tumor, a TURP. The most common procedure, so people had chips taken out, and that's how we made diagnosis of prostate cancer. That was the way things were. Who took care of most of those patients? Our urologic colleagues took care of most of those patients. Hormonal therapy was considered a very benign treatment. It was a treatment that worked. It made people live longer when you had metastatic prostate cancer, and you got a little hot flushes, and if they complained too much, they were told they were whining and just stop. It was just hormonal therapy. That was the era that PSA became sort of introduced. So PSA changed a lot of things in a relatively short period of time. The number of prostate cancer patients went up dramatically. A lot of prostates wound up in buckets and in pathology departments because the number of prostatectomies and radiation therapy procedures went up because a lot of patients were diagnosed with prostate cancer. Medical oncologists began in that era to have interactions with urologists, and again, Dr. Kantoff, who is a little younger than I am, not much, but a little younger than I am, we began to start seeing patients in concert with some of the urologists that we manage patients, and after a while, the number of these patients became increasingly large. The one thing we discovered pretty quickly after the big spike in the initiation of therapeutics in terms of local disease was, by and large, PSA was a harsh biomarker. 30 to 40% of patients who underwent definitive local therapy with surgery or radiotherapy had a detectable PSA post-procedure. And it's a harsh biomarker because obviously in a prostatectomy setting, it tells you that you didn't, in a sense, cure the patient. Radiotherapy was more complicated. That led relatively rapidly to the PSA anxiety environment. So one of the things that I tell people all the time is, and since I have a daughter who's a physician, I could get away with this, I think, for a little bit. What are third-year medical students good for? And since I was a third-year medical student, I know. So they can tell you what the potassium is, because they can look on the computer, but they don't know what to do about it. They know that high potassium is bad, low potassium is bad, and they worry about it, but they don't really know how to intervene. Well, the early PSA era was a very significant anxiety-provoking time, not just for patients, but for clinicians. So you take a therapy that was broadly thought to be a benign treatment, androgen deprivation therapy, and you introduce it into clinical practice to treat a disease. Because one of the things that is challenging for both urologists as surgeons and radiation oncologists is that when they treat localized prostate cancer, our colleagues believe appropriately that their goal is to cure patients. And when you have a biomarker that tells you that you have not cured that patient, or at least suggests that, then there was a great desire to intervene with additional therapy. And one of the things that gets rid of PSA anxiety is to put somebody on ADT and make their PSA undetectable. So everybody's sort of happy. So the problem is that the natural history of this PSA-only disease was not firmly recognized. And for a long time, a number of years, there was a lot of pharmacologic intervention. There were a lot of clinical trials looking at ways to treat PSA-only disease, until eventually pharma realized that, from the FDA perspective, that there was no path forward for regulatory approval of drugs in that setting. So let's fast forward. I'm going to give you 2 patient examples. I think many of you will have seen patients similar to this. A patient who now is about 59, who is an engineer, a lawyer, who has made so much money he runs a nonprofit. In 2008, had a Gleason 3+4, got palladium brachytherapy. Why? That's what he got. 5 years later, he had biochemical failure. He is a very high flyer, sophisticated guy. PSA eventually rose to about 2 or 3, had lots of conversations about the role of early androgen deprivation therapy, was at that time remarried to a woman who was 15 years younger than him. He's a very active guy and was sexually active and felt that was very important. His PSA slowly rose, his doubling time was prolonged. He eventually, about 4 years ago, sought an opinion at a major academic medical complex north of the University of Virginia. He underwent an investigational PSMA scan and was told that he had pelvic nodal disease that could not be seen on CT scan and could not be biopsied, and he should start on hormonal therapy. He sought additional opinions. I've managed this care now for about 4 years. His doubling time now is about 3 months, and 2 weeks ago he underwent CT and bone scan imaging. He has 2-centimeter retroperitoneal nodes, nothing in his pelvis and nothing in his bone scan. The other patient that I'm going to tell you about is a patient who was treated 12 years ago with a radical prostatectomy for a Gleason 3+3. Biochemical failure 3 years later led to salvage radiotherapy. He had biochemical failure that led him to be started on testosterone suppression with an LHRH agonist. After about 24 months, he had biochemical progression in the castrate setting. A clinician started him on abiraterone. He responded for 14 months. He progressed. He was started on enzalutamide. He had a brief response and progressed. He had received imaging, including sodium fluoride PET and CT scans, and never demonstrated metastatic disease through this time frame. Following progression on enzalutamide, he's asymptomatic other than recovering from some of the side effects of the AR drugs. He received 11 cycles of docetaxel. He eventually had biochemical progression. He then received 5 cycles of cabazitaxel for biochemical progression until he no longer could walk because of neuropathy, and he wheeled into my office 3.5 years ago. Castrate, non-metastatic prostate cancer. He was imaged with a CT scan and bone scan, had no evidence of disease. ADT was held. He died a month ago from a stroke without any evidence of metastatic prostate cancer. Interestingly enough, you could imagine the conversation after 3 or 4 years of therapy, including 11 cycles, 15 cycles of a taxane, where he couldn't button his shirt or really sort of he couldn't stand up and close his eyes because he fell down. Trying to explain perhaps why this might not be a good course to continue additional therapy, I thought, this is a guy who's obviously going to be looking at legal action or whatever. And he had the grace to basically say to me, oh, good, I don't have to have any more therapy for a while. So it's an interesting subset of patients. So this is the early set of the story, and we're going to have Dr. Yu here in just a minute sort of bring us up to date in terms of what's happening in this space. And as we go through the evening, we're going to hear a little bit more and move through the disease continuum.
I'll say it's really my pleasure to be here today with such esteemed pre-PSA professors on the stage.
Just one.
But no, it's really a privilege. So I would say that the one thing when I reflect upon your stories, Rob, is that I rewind my clock back to when I was a third-year med student, and when I saw a high or low potassium, I felt pretty confident that I knew what to do with it.
That's why you were invited here tonight.
Well, thank you. However, I feel like only recently did I start to get a handle on, what to do with a high or low PSA. So we're starting to get a little bit more of a handle on that, and so I'm going to talk a little bit more about that here. So, this whole disease state of M0 castration-resistant prostate cancer, non-metastatic castration-resistant prostate cancer, has gotten a lot of attention recently. But I just want to point out the first thing is just that really it's a misnomer, right? I mean, PSA is very sensitive, and what we're really seeing is that it's really a detection of microscopic metastatic disease. And so the idea of non-metastatic is really a misnomer. M0 CRPC, maybe that's a little bit more of an accurate phrase. But, PSA, as wonderful as it is for many situations, also has led to a lot of challenges. It's created a lot of interesting disease states that we don't have with other cancers. You either have localized disease or metastatic disease. And here you can see by this diagram here that we have disease states that are created based on a biomarker, PSA. So you can have biochemically recurrent castration-sensitive disease after somebody has had radical prostatectomy or radiation of the prostate and they've relapsed. And if you treat those patients with androgen deprivation therapy, and I think many centers in the United States will treat patients with that rising PSA because of patient anxiety and physician anxiety as well, then you create this M0 CRPC disease state. Now, there are some centers that may not treat that disease state. I think north of Virginia, there's a big center that doesn't do that very often. They wait until patients have metastatic disease, and that's not wrong. There's no data that says that we need to treat these patients right up front with androgen deprivation therapy, but I think most people end up treating them at some point with androgen deprivation therapy. And when that PSA starts to rise in the setting of being on androgen deprivation therapy with a castrate testosterone level and no radiographically demonstrable metastases by traditional conventional imaging like CT scans and bone scans, then that's what people are calling M0 CRPC. Now, there were really, if you rewind the clock a little bit, not too far back, but just a little bit, there's 4 large randomized controlled trials for this disease state that didn't lead to regulatory approval of their agents. There was zoledronic acid, there were endothelin receptor antagonists like atrasentan and zibotentan, and then there was denosumab, which had a positive trial, but maybe the agency didn't feel it was quite good enough to lead to regulatory approval in this setting. But the nice thing is that we learned a lot from our initial attempts in this field. And this is data from the zoledronic acid bone met prevention trial that was led by Matthew Smith at MGH. And what they learned is that the amount of time it took for patients with M0 CRPC to develop a bone metastasis was actually a lot longer than they initially anticipated. And they rapidly found that they were statistically underpowered to really be able to show a benefit. But Matthew was smart, and he said, okay, we always have to learn something from every study we do. And even though this trial basically was aborted because they weren't able to show the primary endpoint, he said, well, why don't we learn key prognostic characteristics? And that's what they did. They took the control arm, and they looked at absolute PSA value, and they looked at PSA doubling time, and they broke it down into tertiles. And it's easily splayed out here. You can see that the higher PSA patients, the shorter PSA doubling time patients, had a shorter time until they developed bone metastases. So this was used then as eligibility criteria for the next wave of trials. And now you see that we have regulatory approved agents based on this endpoint of metastasis-free survival. Now I think the regulatory agencies were kind of primed to be able to begin to start to accept these endpoints even before this analysis was done, which was the Icecap working group analysis. But I think this helps. And what this analysis did is it took a large number of patients from localized disease studies with intermediate or high-risk prostate cancer, almost 30,000 patients, and they tried to look for intermediate endpoints that might have, tough bar, but the term surrogacy for longer-term endpoints like overall survival. And they took a patient population that had a reasonable chance of dying of prostate cancer, 15% over 10 years, despite undergoing local therapy. And a median follow-up of 10 years, 45% experienced disease-free survival, 45% experienced metastasis-free survival. And really the goal was to take a two-stage meta-analytic validation model to try to find surrogacy with overall survival. What this really shows here is just they did two steps, and they took a true endpoint, and they took an earlier intermediate clinical endpoint. And they tried to correlate that together. And that was the first step. That was condition one. And then they looked at the treatment effect on both of those endpoints, both the early intermediate endpoint and the true endpoint. And the one that came out as the winner, as with having the best correlation across the board, was overall survival and metastasis-free survival. Now, you can argue this is a different subset of patients. This is localized disease patients, and they march through multiple different disease states to get to metastasis-free survival. But I think this kind of data helps to show that there's likely some surrogacy here between metastasis-free survival and overall survival. So that sets the stage for the primary endpoints of the more modern era trials, which is a Spartan trial looking at apalutamide, which we know to be a pure androgen receptor antagonist. And this is apalutamide versus placebo. 2-to-1 randomization, 1,200 patients. And this is for patients with M0 CRPC with higher risk of developing metastases. And that was a PSA doubling time less than or equal to 10-month subset. And they broke them down into stratification factors of PSA doubling time less than 6 months or 6 to 10 months, nodal versus no nodes, or bone-sparing agents or not. And there were multiple secondary endpoints, as you can see there, but the primary endpoint was metastasis-free survival. And I'll just say that this study, as well as the other studies that I'm going to mention, had actually accrued quite aggressive patient populations. So even though they said PSA doubling time less than or equal to 10 months, about 70% of the patients on all of these studies had a PSA doubling time less than 6 months, and we know that to be a more aggressive subset of patients. So when you look at this, you can clearly see that metastasis-free survival is in favor of apalutamide over placebo there, with a nice p-value there. And if you look at other clinically significant endpoints, they evaluated time to symptomatic progression, and that was statistically significant as well. And overall survival, as you can see, was not statistically significant, but that's really because the data is not quite mature. As you can see there, probably at this analysis time point, 75-80% of the patients are still alive. So tough to show that. P-value 0.07, not statistically significant, but I think certainly a very strong trend, if you can use that term, and we feel pretty good about metastasis-free survival as an intermediate.
Can I challenge you on one thing?
Yes, please.
Okay, so the Icecap Initiative was dealt with 30,000 patients with localized prostate cancer, and I think clearly demonstrated the surrogacy of MFS to OS. We're taking a completely different disease state here, that's non-metastatic castrate-resistant prostate cancer, and extrapolating from that experience and saying that, well, it worked for localized disease, therefore it should work for this disease state. Don't you think it has to be proven in this disease state to accept it as a surrogate?
I think it would be nice to prove in this disease state, but again, as I said earlier, and I'll point that out again, I think that the regulatory agencies were ready to accept MFS regardless of the Icecap data. I only put that in there to try to sell a nicer story because I'm, want to march forward a nice story. But even without the Icecap data, they were ready to do that. I mean, with denosumab, I think they gave some pretty clear statements that median bone met-free survival, a 4-month improvement, maybe not good enough. Maybe we'd like to see 6 months or greater. Maybe we'd like to see overall met-free survival rather than just bone met-free survival. So I think there are already hints there. I agree with you completely. We can't say for sure that this is a surrogate for overall survival in this setting. But.
So what are we going to say if, let's say, the Spartan trial, MFS is improved, dramatically, and in the other studies they're going to show improved dramatically, but the overall survival is not changed with further follow-up?
I'm okay with that.
You're okay with that?
I'm okay with that because I think a lot of things are happening in the field and a lot of things are going to happen to these patients after they progress and come off the study. And I think the primary endpoint, statistical endpoint, was for MFS. And, they're clearly close on overall survival. If they hit, even better. If they don't, I'm okay with that. What about you guys?
Well, we're going to let you finish, and then we'll come back at you.
He told me it was okay to ask questions.
Yeah, he's right.
Okay.
Yeah, we're pretty informal here. So, all right, that's fine. So we'll let the challenges come afterwards. But anyhow, as I was saying, not statistically significant here for overall survival. This is an interesting analysis. This looks at time to second progression. And this is an analysis I think that needs to be done more often in more trials. And what they're really looking at is not from the point of progression, then going on to another agent and saying that, the apalutamide arm still does better than placebo, because most of the patients went on to something like abiraterone. But what this really is taking from the point of randomization, time point 0, marching them through progression, then the patient comes off apalutamide or placebo, and then going on to the next agent. And that total time frame was still better for apalutamide over placebo. It's not from first progression to second progression time point, but from the beginning to second progression. I think the principle here that's being shown is the fact that earlier treatment does not do harm. The fact that you're giving apalutamide earlier than you normally, or enzalutamide, et cetera, and we'll show that data from other studies, but you're giving it earlier, and do you create some sort of super beast? You're giving apalutamide earlier, whatever becomes progression, at the point of progression, that disease is so resistant that actually you're not gaining anything by giving it earlier. That you're not gaining anything overall because you've created a super beast that's not going to respond to something else. And I think this is nice to show that even though you're given this earlier, the patients clearly do better in terms of metastasis-free survival, but they're still doing better overall. You're gaining enough up front to make it worthwhile. Now, adverse event, I'll just point out a few things here. Apalutamide certainly still causes a little bit more fatigue than placebo. Rash is something we're going to pay some special attention to because that's kind of a newer side effect, but you still see a little bit in regards to falls, and if you fall, then you're at risk for fractures. And there is some hypothyroidism as well, but there really isn't any significant concern with seizures. And that's one thing, is it's thought that apalutamide might cross the blood-brain barrier a little bit less, but I think you'll see across the board with these agents, seizures are just not a major concern. But rash is something that we see, and I think that it's something that there are ways to address and to pay attention to. So here's some data on rash. It was 24% of patients versus 5.5% on the placebo arm, and 5.2% of the patients treated with apalutamide versus 0.3% experienced a significant rash grade 3, which is greater than 30% of the body surface area. Onset occurred after about 2 to 3 months, but it resolved in 81% of the patients. And only 4% received systemic corticosteroids, so it was usually treated with topical agents. It did recur in about half the patients who were rechallenged with apalutamide, and 28% had dose interruptions, 12% with dose reductions, and discontinuation in 9% of cases. So, it seems like it's generally manageable, but there can be some cases that can be challenging. Now, this is the next randomized controlled trial. This is the PROSPER trial, and this is with enzalutamide versus placebo. And I won't spend a lot of time on the study design because you'll see that it looks incredibly familiar, and it's quite a bit of commonalities across the board with all these trial designs. But this also led to significance in terms of metastasis-free survival with enzalutamide as well. And I think that this proves the principle that these pure AR antagonists clearly have some efficacy in this setting when looking at metastasis-free survival. Now, they had some different secondary endpoints with this trial. So they looked at time to first use of the new anti-neoplastic therapy as one clinically significant endpoint, and that was also clearly in favor of enzalutamide over placebo. But again, you can see the common theme in the overall survival analysis of not being statistically significant at this first interim analysis. And again, that's not surprising because most of the patients on the study are still alive at this analysis time point. Now, here are the adverse events. And one thing I want to point out is that adverse events are measured differently across studies. So everybody always wants to do cross-trial comparisons, and we all say we don't like to do it, and then we proceed to do it. But I'll say that the apalutamide trial has higher rates of adverse events across the board, not just for the treatment arm, but also for the control arm, because they asked for adverse events on a monthly basis. Their CRFs recorded them monthly. On this trial and the next trial, it was every 4 months. So the overall adverse events rates are going to be lower on these trials when you query the patient less often. You can see a few things here. There's hypertension here with enzalutamide, and we know that this occurs. It's different than the hypertension with abiraterone, where it's fluid excess, mineralocorticoid excess. This is more of an arterial hypertension that we occasionally will see. So we're not going to use diuretics here. This might work better to use a calcium channel blocker or something. But there's fatigue there as well, and falls look to be pretty similar to placebo, so not too bad. And I'll move on to the third trial, which was the most recently read out trial. This is the Aramis trial. And again, a very similar clinical trial design, but this was with darolutamide, 1,200 milligrams, plus androgen deprivation therapy versus a placebo and androgen deprivation therapy as well. Metastasis-free survival is the primary endpoint as well, and a similar looking graph, as you can see. Also statistically significant, 59% reduction in risk of distant metastases or death. And overall survival here, I'll point out, we're used to seeing p-values less than 0.05 in each year. But again, this was at the early interim analysis time point. So they have very clear rules that at their first interim analysis, you have a much, much higher bar to achieve statistical significance. I can't remember the exact number, but it had a lot more zeros there. So one cannot say that this is statistically significant for a survival benefit at this point in time. At the final analysis, if the p-value looks like this will be statistically significant. So just to clarify that point. Here are some key secondary endpoints they looked at, other than overall survival, time to pain progression, cytotoxic chemotherapy, first symptomatic skeletal event. These were all in favor as well of darolutamide. And more recently, we've seen here at this meeting, time to deterioration of quality of life measures, urinary symptoms, bowel symptoms, also in favor of darolutamide. In regards to adverse events, it looks pretty favorable as well. A little bit more fatigue. Again, seizure is not really a concern there. Fractures and falls, not a real issue here, so that's kind of nice. But the thing I want to point out is we all talk about next-generation PET imaging, and I already mentioned that non-metastatic castration-resistant prostate cancer is really a misnomer. But now that we have all these new imaging modalities like flucyclovine or doing more PSMA PET imaging, is this disease state going to shrink? Is this M0 CRPC really between a PSA of 0.1 and 0.5? And we're going to be finding metastases at a really low level. I mean, we have choline PET available at certain centers, sodium fluoride PET, highly sensitive for bone mets, flucyclovine is regulatory approved, and we have different forms of PSMA PET that are coming. So here's my thought on the process, okay? I'm only obtaining PET imaging for castration-sensitive biochemical recurrence because the concept of finding oligometastatic metastasis-directed therapy is feasible. I don't know if it's right, but it might be feasible at that point in time. For castration-resistant prostate cancer, I'm not doing it because it doesn't change my practice, because I can give these patients, right now, agents like apalutamide and enzalutamide. Prior to having these agents, sure, I might have done it to look for being able to give Sapulcel T early or early abiraterone or enzalutamide, but I don't need to do it. So my approach is if you have somebody who's next-generation PET imaging positive only, but still CT scans and bone scans are negative, I still consider that M0 CRPC because they fit the eligibility criteria for these trials. But these imaging modalities for castration-sensitive disease might drive the idea of ablation of oligometastases. And I'm just going to have a few slides here behind the theory of ablating oligometastases. This was a nice Nature paper that looked at whole genome sequencing and tracking the fact that metastases from the prostate cancer, primary prostate lesion itself, are not the only metastases that are derived. They don't just all come from the primary lesion. Mets can beget more Mets, and they can leap from one metastasis to the next. So it might lead credence in theory to the idea that maybe we ought to ablate some of these metastases to delay that from happening. And there are some studies that are out there. This is a randomized controlled trial, the only one that I can think of right now that has been published for prostate cancer, the STOMP trial. And these were patients that underwent choline PET. And if they had 3 or fewer oligometastases by choline PET, they were randomized trying to delay the time to androgen deprivation therapy. And they tried to preset androgen deprivation therapy as symptomatic progression, progression to 3 or more metastases, or local progression of known metastases by choline PET. And they were randomized to either metastasis-directed therapy, which you could repeat, or to just observation until they reach one of those clinical endpoints. And here's the data, the intention to treat per protocol analysis. And because this was a small trial, they set their alpha, I believe, at 0.1. And the per protocol analysis was p-value 0.08, significant in improving ADT-free survival. But they also looked at PSA and biochemical recurrence-free survival as well, which was in favor of metastatic directed therapy with either surgery or radiation to the oligometastasis. It is a little bit interesting that the observation or surveillance arm had quite a few patients with PSA declines in that waterfall plot. I think that's a little bit unusual, but this is kind of the first kind of randomized trial to show some sort of potential clinical benefit, and one can argue that we have a lot of patients that want to avoid androgen deprivation therapy, so this might be considered.
I'm very skeptical of that result. Not that I don't believe the result, but what's a few months of waiting for the next metastasis to pop up because you had radiation to a metastasis, right?
Yeah.
I mean, if you had a third arm of ADT, even for a year in that study, it would have blown away the PFS curve, right? So metastasis-directed therapy, interesting concept, but I don't see many people being cured by that.
I agree with you. And again, so cure is one thing, but there are people who go into it and physicians who counsel their patients and say, we're not going to cure you, but we're going to maybe reset the time clock.
Delay ADT.
I'm not saying that that's the right thing. I don't know. But, it's a randomized controlled trial. They got into the JCO. It's gotten a lot of attention. It has its flaws, right? And so we need to do a lot more work to know whether it's the right thing to do or not. Right
there
now,
may be
it's
some
just theory.
patients in there who were cured by that radiation. I mean, there is a tail on that curve. But what I'm saying is I think it's too early for us to say this should be something we should be thinking about in all patients.
And I do not
agree.
do that.
I agree.
Right.
Because I don't think, we need proof that we're curing patients, and that's not here.
Right.
We need bigger studies, et cetera. But what is the value of delaying ADT, giving SBRT to 2 or 3 lesions? And I'm not sure.
I don't know either, and I would just say this, is that this is just the start, and part of my summary is just to point out that there are many trials that are being planned with longer-term outcomes and endpoints, many of which through the cooperative groups, and we'll just have to wait and see, but this is just...
Suffice to say, if somebody got radiation to 2 Mets in the bone and they had a year free of ADT, they might take that offer because the SBRT, the radiation that they're getting in that STOMP format is not very toxic.
Right.
I'm just wondering if at the end of the day, we haven't affected survival, we haven't affected the big long-term things. It's way early to answer that.
Right. What does oligometastatic disease mean to you?
Good question. Probably 4 or less metastatic lesions, although I might qualify that and say it could be any number of metastatic lesions that could be fit into a radiation field or something like that. Depends on what you want to do with it.
Well, it depends upon the imaging.
Yeah.
What kind of imaging? Standard imaging?
All right, so wait a second. So he asked a very important question. So where do those 4 lesions come? What imaging technology is it?
Well, I was thinking technician bone scan, but...
So conventional imaging?
Yeah, but Dr. Kantoff is going to take me to school on this because he's right that it does matter about we have better imaging now, so...
All right, so I'm going to ask 2 questions of each.
Well, let me just finish that
All right.
thought. And it depends upon what imaging, it depends upon what disease state, because if you're talking about a rising PSA population, that's a very different oligometastatic disease context than somebody who has already been through ADT.
Mm-hmm.
So, all right.
Okay.
I'm going to ask Evan in a minute, but I want to ask the 3 of you, what is outside of a context of a clinical trial, what is your current practice with regards to the use of next-generation imaging?
Well, I was at a center with liberal use of PSMA PET, and we did that for 2 years, and I got addicted, right? And it was great. Which I meant was we saw a lot of people, we did PSMA PETs, and we would radiate the lesions, right? And I sold it to people like, we can delay ADT, maybe we're going to cure some people, et cetera, et cetera. And then I moved to a place where we don't have it yet, and it's something like I feel like I lost that tool.
You became more skeptical.
Well, but that's my point. Is at the same time I said, wait a minute, what was I doing?
But there is a center within hailing distance of you that has a particular access to next generation imaging. Do you not utilize that?
Same state.
There's another center in Minnesota?
There is another center in Minnesota.
I'll have to look at a map when I get back, but but no, I can get next generation imaging. It's just not as easy as it was before.
So what is your current practice? Because your current practice, it really more mirrors that most clinicians face.
Yeah, so I've seen cases based on my prior experience in California where we had people with a rising PSA after radical prostatectomy. You do the PSMA PET scan, and lo and behold, you see a chain of lymph nodes that weren't dissected or weren't that could be radiated or something. And I did experience that gratitude for the scan where you feel like you've done something good for the patient. But that was over the course of 2 years, and I don't have the long-term follow-up on those patients I treated, right? And so that's my point to Evan, which is having switched to a place where it's a little bit harder to get, I'm sort of thinking, okay, maybe we need to get this validated. Maybe we need to be a little...
So that's fair. So Dr. Kantoff, your view about next generation imaging outside, and you have a major center that's done this work, so I realize...
Well, it's not available at our center other than a protocol, and the protocol that we use is in the rising PSA population. My feeling about it is, obviously it's much more sensitive, and if the scan in a rising PSA population or person is negative, it gives me greater confidence to give salvage therapy, local salvage therapy. I don't know that. That needs to be proven.
That's fair.
But I feel more confident in that context. There are some patients who have oligometastatic disease as defined by this scanning in this disease state, that I will do SBRT on, not knowing what the impact of that is.
Dr. Yu?
Yeah, so what I would say is this, is that we have a couple flucyclovine protocols, and when I discuss this with patients, I would say that the vast majority, if they're going to undergo next generation PET imaging, my conversation is this: if you're just going to do it, we don't want to order tests that we're not going to do something about. So I have the discussion of, if we were to find theoretically 1 or 2 spots, knowing that we don't know the long-term outcomes, would you want to go after it? And I have that conversation with the patient first. If they say, yeah, I'd want to know, I offer them 3 routes. I offer them, and it depends upon a lot of factors. What's the absolute PSA? What's the PSA doubling time? If it's too indolent of disease, I don't want to mess with the patient. If it's too aggressive a disease, I think maybe it's too late. So I try to find something in between.
That's the crux of it right there.
Right.
It's the Goldilocks.
Right.
You've either got too little or too much.
Just like all adjuvant therapy, right? It's either too late or you're not going to help the patient, or they don't need it because they're already cured. So there's that sliver.
Yeah, exactly.
And where's that sliver? And so, anyone's guess is as good as mine, but, I set it based on PSA doubling time and some absolute PSA values, and designed a couple different protocols using flucyclovine to direct therapy, because we don't have PSMA yet. We will eventually. And that's my preference, is to put them on protocol. Now, are there occasionally some patients that don't want to go on protocol? Yeah, there are, but that's how.
So there's a guy named Ken Pienta, who's one of the brightest minds in our field, and he did a really interesting thought experiment, published it a couple years ago. And what they talked about was they looked at circulating tumor cells, and they said if you take one 7.5 ml tube of blood and you have 1 circulating tumor cell, and you multiply that times 5 liters of blood in a patient, you can do the math, you can figure out how many cells are in the circulation at that time. They also took bone marrow biopsy data on disseminated tumor cells, and they said if you had 1, however big the core is of a bone marrow biopsy, 1 disseminated tumor cell in that bone marrow biopsy, and you generalize to the total volume of bone marrow, you're going to have multiple millions of cells. And they basically did the calculation that this can be done in people without metastasis. And the calculation was that you had to have 2.4 billion cancer cells in your body before you had 1 metastasis. Now, it's a thought experiment, right? But the idea was, as I've sort of said to patients, that means you could have 2.3999 billion cancer cells in your body and have a clean scan, right? And so the point is, if somebody has this oligometastatic phenomenon, how can we be sure that you've got 2.4 billion cells producing that one tumor, and you've probably got another couple billion out there circulating around? And so it's a systemic disease. We've been preaching that for a generation, and now all of a sudden we have these new scans, and we're saying, oh, it's not general, now we can do all this good stuff by finding these 2 spots in these rare patients. So, long diatribe, but I think it's a valid question, is we shouldn't abandon this thought that we had that this is a systemic disease that causes recurrence after surgery or radiation.
Completely agree. I think if the discussion is going to be had, I think it's a remote possibility that we're going to be curing people, in my own mind. But you can use the argument that it might delay the time before you need systemic therapy.
I love curing people as much
no.
as anyone else, but I mean, again, I'm not planning on curing that many people.
I think we can cure a lot of people.
Some people.
I think we can cure a lot of people, but we have to use radiation and a systemic therapy that eliminates those billions of cells that are circulating around.
And honestly, that's the reason why, everybody does SBRT, SABR to these Mets, but I don't love that, because we know when you look at the positive predictive value of these imaging studies, they're quite good, but the negative predictive value is quite bad. And when you do lymphadenectomy surgically, you're a positive node, you found that on PET and you took it out, but right by them, there are a lot of other positive nodes. You kind of got to go a little broader if you're going to do it.
So we're going to transition on now and start talking about a little bit more advanced disease, and I'll invite Dr. Kantoff to talk about patient and experience.
Well, the question is it more advanced or just different? That we're going to be talking about metastatic hormone-sensitive prostate cancer, and I'm going to present a case, and then Chuck is going to talk about the data that is behind it. So I'm going to tell you a patient story. So he's 60 years old, he's otherwise healthy, and he comes into his doc and has a PSA of 25, repeat 25. Biopsy of the prostate reveals multifocal Gleason 4+4, so this is an aggressive, high-grade prostate cancer. He has an MRI of the prostate which shows a single PIRADS lesion, that's PIRADS 5, and he has bilateral seminal vesicle involvement. So it looks like he has locally advanced, high-grade prostate cancer. A bone scan shows 2 lesions that are equivocal, one at T10 and the other in the left acetabulum. There's enough equivocal here, although it's a high-grade, high PSA situation to warrant a discussion about a biopsy, and a biopsy is done of the T10 lesion, and it does show prostate cancer, and it stains positively for PSA. So a discussion ensues when he comes to me about whether to use ADT alone or a combination of ADT plus local therapy. The argument that local therapy might be effective here comes from the Stampede study, where local radiation did improve survival in low-volume metastatic disease. Should SBRT be used here for those 2 lesions? Should other systemic therapies be used, such as chemotherapy or hormonal therapy? Well, after the discussion, the patient opts for a combination of ADT and abiraterone. You'll hear the data on that, and also opts for local RT on the basis of the Stampede data. There's a discussion of genomic assessment here. We already have tissue from his biopsy, which can be used. We get a germline assessment, and the patient is all for this, signs consents. And given the aggressiveness of the disease, we felt it was advisable to find out if there are any important abnormalities that are potentially actionable, in particular DNA repair abnormalities. And this patient has a germline BRCA2 mutation, also has a hemizygous RB1 deletion, and the somatic analysis shows only variants of unknown significance.
So the BRCA2 is a VUS? It's not a pathogenic?
No,
it's a pathogenic.
It's a germline pathogenic mutation. So the patient stays on ADT plus abiraterone after receiving radiation for 2 years. Restaging is negative, so the lesions on bone scan have now cleared up, and then the therapy is stopped. It's sort of an intermittent hormonal approach. and he's observed after 1 year of observation, his PSA climbs to 0.5. Testosterone is up from castrate levels to 90 nanograms per deciliter, and there's faint reemergence of the two bone lesions. He's asymptomatic. So discussion ensues. Should we continue to observe? Should we resume the ADT alone, or ADT plus abiraterone? Should we use SBRT here? Should we use a PARP inhibitor given the fact that he has a BRCA2 abnormality? So in this case, SBRT is administered because the patient would like to stay off of the androgen deprivation therapy and abiraterone for a longer period of time. The lesions disappear. The PSA does go down as a result from 0.5 to 0.2 from the SBRT, but after 6 months, the PSA begins to climb. It's up to 0.8. Testosterone is continuing to rise at 120. Scans continue to be negative. So the discussion now is, do we continue to observe? Do we use Sipuleucel T? Is it appropriate here? The patient is not really castration resistant here, so not appropriate for Sipuleucel T, although there was a question about it. Do we go back to ADT alone or ADT plus abiraterone? What about enzalutamide? What about docetaxel? So the patient continues to want to be observed. He didn't like his first encounter with ADT and abiraterone, and his testosterone continues to increase to 350 nanograms per deciliter. The PSA is now 5, and the bone scan shows widespread metastatic disease, but he's asymptomatic. So the options now are ADT alone, ADT plus abiraterone. Do we add instead enzalutamide, docetaxel? You'll hear about all these options. Olaparib. Well, olaparib is not quite indicated at this point, not castration resistant. Radium-223, not quite indicated in this situation, not castration resistant. So the patient goes back on ADT plus abiraterone. PSA returns to undetectable, but 6 months later, his PSA begins to climb. Testosterone is less than 10 nanograms per deciliter. So by definition, he now has metastatic castration-resistant prostate cancer. The bone scan shows progressive disease, and the patient is mildly symptomatic.
Dr. Ryan, what do you think about the management of this gentleman?
So one of the things that was done with this patient, which is very interesting, is he got 2 years of ADT plus abiraterone, which is a thoughtful choice, really, even though in the Latitude studies and the studies that we all know about, it was continuous, right?
But Stampede was 2 years.
Stampede used it for 2 years for the patients who were intent to receive radiation, I think.
Well,
right?
no, Stampede G.
But they didn't come off ADT. Like, in other words.
That's right. ADT was not.
So, in other words, what this did was this asked the question, and I've asked the same question, which is now that we've got better AR targeted therapies in the form of all the new drugs, can we rethink intermittent hormone therapy? In other words, I think it was reasonable. It was not really supported by data, but it's reasonable in situations like this where people take the Abby and ADT for 2 years in a low volume metastatic setting to consider going intermittent. And I've thought that through with patients. Now, I'm very cautiously saying this because there's really not a lot of data to suggest doing it. So,
or actually, you're being very cautious by saying there's like no data.
Well, but then he goes back on the ADT and the abiraterone, and his PSA goes back down to 0, and then he gets CRPC. But you can't make the this after that, therefore because of that logical error. In other words, he would have probably gotten CRPC within 3 years anyway.
So let me ask you. So all that's fair. He had very poor risk biology, right? He's got gleason-8. He's a BRCA.
Yeah.
Is that the kind of patient that?
Well, it's bad, but it could have been worse. So I looked at it and I said, okay, we don't know about TP53. 50% of patients have TP53 alterations. That's a really bad prognostic factor.
Or RB is probably the worst thing that he had.
RB is the worst, but if he had P10 or P53 with the RB,
yeah,
that'd be awful.
So he's got bad biology. That's
right.
True, and you kind of know where the story's going when you see that, and that's I think a really important point. Guidelines are evolving, and we're getting to an understanding where we should be sequencing patients earlier because we've got the PARP inhibitor story that's unfolding, we've got the MSI high story that's unfolding, but also even when you don't get one of those two very actionable mutations, as we're saying, we now can look at these mutations, the RB, the P10, the TP53, and we get a better picture of what's in store for that patient, and that may color things for us in terms of how we do that.
And with that, why don't you segue and tell us about
Why don't I give a talk on this?
Can I just ask real
Yeah.
quick, Phil? You put him on the actinium trials, my guess, right?
In this case, no, I treated him with conventional therapy.
I mean, I like that choice.
Yeah,
Right?
I do
Double-strand
too.
DNA break.
I thought it was a little bit early
Yeah.
for this patient, but that's where he's heading.
Yeah.
The sort of the paradox we're facing right now is for years we've treated this disease a little bit like, sailing in a gentle wind. We'll ride the wind for a while with whatever drug, and then we'll shift gears and take the next wind, and we kind of go slow and we wait for the disease to progress and we treat it. But now we have this mountain of evidence coming at us saying earlier is better, whether it's docetaxel, abiraterone, or whatever. And so in a case like this, it makes sense.
But the only thing, and you've all said it, but we have to remember that early versus late therapy is always a question, right? At the end of the day, unless we demonstrate survival benefit, it may be a game of moving the parts around, but the end is different, and the toxicity profile and impact on quality of life in a patient population that in general is older. I'm not talking about the 52-year-old, but if the median age of 68 or 69, some of these issues in terms of duration and toxicity of therapies have to be considered.
So just for the sake of argument, I'm just going to throw out there that we can only do so many clinical trials, and that what we have are a series of studies now that we can extrapolate from that say you move things up earlier, when the volume of disease is lower, you have a better benefit. So giving this patient docetaxel in this early CRPC setting where he's already abiraterone resistant seems very prudent, even though we don't have survival data on how it looks when you give docetaxel after abiraterone in hormone-sensitive disease. Okay, so I'm going to talk about science, recent advances in metastatic HSPC and new approaches. So first of all, we talk about metastatic disease as if it is one entity, and the reality is a person who has a radical prostatectomy, his PSA rises, and 3 years later he gets a metastasis, is a different kind of patient from somebody who shows up in the emergency room with back pain and has de novo, untreated, never been diagnosed metastatic prostate cancer. That latter patient, that de novo patient, has a much worse, probably a much worse biology, and clearly is entering the treatment fray at a more advanced disease stage. So keep that in mind as you think about how to interpret the data and as you think about customizing patients' treatments. So yes, Charted, Latitude, and Stampede. These are the three big studies in the hormone-sensitive disease. We now have a bunch of new ones, Titan, et cetera. But what these studies did is they took metastatic patients. Most of them were de novo. Some of them had had a radical prostatectomy and then relapsed. But I believe in Latitude it was like 85% were de novo. Charted, they had two cohorts that were prospectively studied, high volume, as stated here, and low volume. Latitude, all patients were required to have two high-risk prognostic features, like a Gleason score of 8 or higher, more than 3 bone mets, or visceral metastasis. It was basically the high-volume group of Charted, and Stampede is a very broad study, really innovative. Thousands, I think 11,000 patients in the UK now on the Stampede study, but most of them are newly diagnosed metastatic, some with node positive, some with locally advanced disease. So when you read the Stampede data, you really want to focus in on what patients they're talking about. Okay, because it's actually a little bit broader. That's to their credit. It just it has to have us as the interpreters of that be a little bit more on our toes. So here's Charted. It's been out now a few years, published in the New England Journal of Medicine 4 years ago, and this was a study that really changed a lot because it took, as I said before, this concept of let's wait and do everything, and then at the very end give chemotherapy, and it flipped that, literally. And it said, let's give chemotherapy first. And what's going to happen when we do that? Well, what's going to happen is we're going to see a substantial survival benefit. And this was the first outcome analysis that came out from it. And lest you be unimpressed from this Kaplan-Meier curve, look at the median survival here, 58 months, 57.6 in the docetaxel arm versus 47. That's a 10-month survival difference. That's pretty significant when you compare to how we talk about the medians in CRPC, where we were typically talking about a 3 or 4 month. But I urge you, as I do and as I teach fellows and trainees, the median survival is not the take-home message of any of these phase 3 trials. It's the gap between the arms over time. It's the risk over time. And with a hazard ratio of 0.72, giving chemotherapy for 6 doses reduced the risk of death by 28%. And if you said that to a patient, I can give you 6 doses of a drug and it will reduce your risk of death by 28%, most patients will take that. Well, they'll understand that better than talking simply about the median survival, which is just one point in time, okay? But as we broke it out, we learned more about chemotherapy, and what evolved is this really interesting question. But it suggests that the chemotherapy benefit was preserved only in the high-volume patients, where you saw a difference in the median survival go from 34.4 months with ADT alone versus 51.2. So that's a 17-month improvement in survival, and that's a hazard ratio of 0.63 with a reduction in the risk of death by 37%. So that's quite significant. But on the flip side, what was really interesting is the docetaxel did not appear to benefit the low-volume patients. And again, if we're thinking earlier is better, let's hit it harder in lower volume disease, this low-volume group of patients should have done better than the high-volume group of patients, but they didn't. They did worse. And we haven't really figured out why. Is it because the high-volume patients have high-volume disease because they have some sort of worse biological feature? And is it that worse biological feature that renders them more sensitive to chemotherapy? These are all good questions, and we don't have the answer to it. So what we would love to know is, are these high-volume patients the ones we just talked about with the RB loss and the P10 and the P53? It'd be great to know that data, and some of the studies that are ongoing are trying to spell that out for us. Going back to the Denovo versus prior local therapy, and we see that even though I said that the diseases are two different diseases, the Denovo patients still had a worse outcome than the prior local therapy patients. However, they both enjoyed a benefit when they received docetaxel. You would look at these with a different perspective. You would conclude that in either case, somebody who's showing up to your clinic with metastatic disease that is untreated without hormone therapy going should or could benefit from docetaxel-based chemotherapy. And then this is the low-volume Denovo with low-volume prior therapy, again demonstrating that the docetaxel didn't really benefit either group of patients. Do you want to comment on about the molecular subtyping?
Yeah, all I can tell you is at the genomic level, there is no, in using panel sequencing, there's no apparent difference in the frequency of the known bad mutations in low volume versus high volume. So maybe there are probably
in the one piece of tissue that you have from each patient.
In the one piece, yes.
And so that's the other thing is obviously we can't do this, but if the high volume
that
patients,
is what we know now,
by definition, have more tumors, there's more heterogeneity that could be evolving there. So anyway.
Good point.
Okay, here's Stampede, more diverse in terms of its patient population, but again, validating this theme of with a 22% risk in the reduction of death with the docetaxel. In this case, the standard of care, the docetaxel arm, the median survival was 81 months. And the docetaxel from the charted, this is the UK, the charted study in the US had a median survival of 57 months, more or less. Here it's 81. It's because they had patients with lower volumes of disease coming in. And so you can't say that getting chemotherapy in the UK is going to lead to better survival than getting chemotherapy here. It's a different patient population. And so that makes it hard to do these cross-study comparisons. However, they do directionally validate one another, and I think that's the key point. So meta-analysis was published. It's worth looking at, and the circle here answers the question that I asked before, which was 87% of the 3 studies that were analyzed, including one from France that we don't talk about, but was a smaller study and was negative. 87% of the patients studied on these trials had de novo metastatic disease. Here's the Latitude design. Basically took the high-volume group of patients that we just talked about. It was a study conducted largely outside. It was outside of the U.S., but it did include 34 countries in Europe, Asia, Latin America, and Canada. So it was a highly international study of about 1,200 patients, 1-to-1 randomization. And remember those high-risk features I mentioned: Gleason score of 8 or higher, 3 or more bone lesions on a scan, or a visceral metastasis. And if we want, we could talk about visceral disease and what that means. But the idea here was continuous therapy with abiraterone and ADT versus ADT plus placebo, and it was placebo control, which is important. Here's the RPFS data demonstrating a significant improvement, a greater than 50% reduction in the risk of progression over time for those receiving abiraterone. Medians 33 months until the time of radiographic progression. Now think of Dr. Kantoff's patient. He was on abiraterone for 2 years, came off ADT, did nothing for a while, then goes back on ADT plus abiraterone for another 6 months before he gets CRPC. So he was almost like exactly at the median. He was 30 months of abiraterone and ADT before he got CRPC, but he had about 12 months of no therapy. So he was really better than the average, if you will, 55 months if you count the time he spent off of therapy altogether. Again, making us raise that question of could we do intermittent therapy in these kinds of patients? Here's the overall survival. Now, I like to teach two things about this curve. One is it's great to see this, 38% reduction in the risk of death, statistically significant, round of applause, and we should be happy. And now we have, if you're interested, a non-chemotherapy option for these patients. But I actually like to take this Kaplan-Meier curve and flip it upside down, or look at it from the photographic negative, if you will. What's striking to me is that if you look at 2 years after initiation of ADT, 22% of the patients not only have experienced progression, they're dead after 2 years. And if you look at that 36-month time frame, about 33% of the patients on the abiraterone arm have died after 3 years. So while we should be happy we've improved the outcome over ADT alone, there's still a lot of people when they present with Denovo metastatic disease experience early progression and death, and we can do better, I think, with different approaches that we might get a chance to talk about. So here's the summary of the updated overall survival results from the Latitude study, and you can again appreciate the statistically significant nature of this. So this is the abiraterone group from the Stampede study. Again, directionally supportive, a 37% reduction in the risk of death over time. And in this group, again, if you look at my 24-month and 36-month rule, you see that the Stampede patients largely are doing a little bit better than the Latitude patients, probably because of risk selection and many more patients with lower volumes of disease. Here's the Stampede study for patients with overt metastatic disease. So in Stampede, there were patients with locally advanced disease, with lymph node only, and patients with metastatic disease. And so this is probably our best comparison for the Latitude study and even the Charted study. You can see great separation of the curve, wonderful, statistically significant. Again, if you think about what's happening at 2 years, you see again about maybe in this case 20% dead after 2 years, and after 3 years you're seeing about 25% or so have died. So still a significant number of patients at risk. But if you look at the Stampede patients who entered this trial without metastatic disease, these would be the locally advanced patients, they're all doing quite well, and the curves haven't really separated. And that's after, the number at risk down below would suggest that we need these data to mature more, but after a few years of treatment, these curves have not separated. So that to me is really interesting, right? Latitude, you got 33% of patients are dead after 3 years. The non-metastatic group, who still, by and large, had high-risk features, almost no deaths in that time frame. It just kind of underscores this notion that if you have more tumors, you're more likely to have tumors that harbor bad biology, is sort of the way to think about it. And the reality is that this slide, is it obsolete as of today or yesterday? It's getting there, right? Current options in metastatic hormone-sensitive prostate cancer, docetaxel, abiraterone, all of them based on randomized trials showing progression-free survival advantages as well as overall survival advantages. So I think us clinicians in the US and elsewhere, we can feel comfortably sitting down with patients and offering them either ADT plus abiraterone or ADT plus docetaxel. We could talk for a long time about the relative advantages of each of these. I like to think, for example, that the docetaxel is interesting in that you give 6 doses of a treatment and then you stop that treatment. As I say to my patients, you invest your time, 16 weeks of your time in taking chemotherapy, and what you're getting is, in that high-volume group of patients, you're getting many, many months, even years of return on that investment in terms of improved survival. And I think that that's really important to talk about. Whereas with abiraterone, you don't have the risks of chemotherapy, but you do have a relatively long daily dose, use of a daily dose of a therapy. You require the prednisone, et cetera. So there are advantages and disadvantages to both approaches.
What about the argument that the only benefit of docetaxel is seen in the high-volume patients?
Right, so I don't even really talk about docetaxel in the low-volume patients.
Right.
Yeah, thank you for clarifying. And the other thing I want to just point out is, I don't think I have a toxicity slide, is there were deaths from docetaxel. We've had them in our clinic from patients with hormone-sensitive disease. It's rare, but it does occur. It's rare to see a patient die of abiraterone. I don't think I've actually ever really seen it, knock on wood. So when, that is something to think about, is that there are toxicity-related deaths when it comes to chemotherapy. But in most cases, when patients who don't experience pulmonary toxicity or life-threatening infections due to underlying illnesses, docetaxel can be administered quite safely. So we talked a little bit about what to do in the case of the post-abiraterone patient who progresses. Flip that around. If we think about the post-docetaxel patient, let's think about that charted patient who does very well. He gets his chemotherapy, everything's good, and then he goes on to develop progressive disease. There is a study for that being done in ECOG, one of the cooperative groups, which is asking the question of should we do chemotherapy plus abiraterone versus abiraterone alone in that setting. And this study is called CHARTED-2. It's not a redo of the CHARTED study in the same patients. It's actually like the second line for CHARTED patients is the way to think about it. And so that study's underway in ECOG, and it's a relatively small study, randomized phase 2, but interesting question. I'm going to buzz through a few studies that are reading out that are important. ARCHES, 1,100 patients with metastatic hormone-sensitive prostate cancer, allowed a wide range of patients, high versus low volume disease, and actually allowed some patients who had received prior docetaxel, and they went on enzalutamide on daily use until radiographic progression. This study started in 2016 and is now reading out, and as you can see, nicely, there's a significant advantage to the use of enzalutamide here with a hazard ratio of 0.39. So it's a 61% reduction in the risk of radiographic progression when you add enzalutamide to ADT. Now, we should go back, and we were joking about the pre-PSA era, et cetera, but there were a series of studies with flutamide, flutamide and bicalutamide, and I think even cyproterone and nilutamide.
19 studies.
Okay, 19 studies that consistently showed no benefit. I mean, how many patients went on those studies? And these drugs, enzalutamide, is, just a better version of those, right? And look at this amazing radiographic progression-free survival. So by sticking with the same target and sticking with the same backbone of the drug and just improving the potency of these drugs, a huge difference. And so that's really quite remarkable that sticking with a focus on the androgen receptor over the course of decades resulted in this benefit. So this is an abstract looking at some of the key secondary endpoints of the ARCHES study, which I believe is what's abstract 5048, Andy Armstrong from Duke. And this is interesting. So the patients who had received prior docetaxel still benefited from the enzalutamide. I don't think that's a real surprise. The numbers are trending in the right direction to say that if a patient has high volume disease, maybe perhaps, and you give them docetaxel, maybe there's a benefit to putting them right on an AR targeted therapy after that. Not quite sure about that, but that's something to think about. I look at data like this and I think about three phases of hormone-sensitive disease. There's this initial remission induction, your initial slam on the tumor. You're bringing that PSA down, you're shrinking those tumors. Then there's sort of this maintenance phase where the PSA is low, and hopefully that lasts a long time. And then there's progression of the disease, right? And is this enzalutamide after docetaxel, is it delaying the progression of the disease? Because it's probably not getting that initial remission induction that we would do if we started it on day one, if that makes sense. So these are the kinds of questions that we think about, and whether that's relevant or not, I don't quite know, but it's worth thinking about. The no prior docetaxel, this is the curve here. The Kaplan-Meier curve looks very similar. And so back one slide, you had a hazard ratio of 0.53. Here you have a hazard ratio of 0.36. So if anything, it's a little bit better. The numbers are a little higher here, and it suggests, that enzalutamide plus ADT is probably sufficient versus ADT alone, and that the docetaxel, if given, may not add a ton. So it's conflicting data a little bit, so we'll have to learn more about that over time. Here is the aforementioned TITAN study. Apalutamide plus ADT versus ADT plus placebo, 1,000 patients. These are all beginning to look very similar in terms of their design. That's actually a good thing in terms of our ability to try to make some cross-study comparisons. And you can see here there were stratifications around prior docetaxel. And here is the efficacy outcome of progression-free survival with a 24-month readout. 68% were progression-free at 2 years with apalutamide versus 48% versus placebo. And that's associated with a hazard ratio of 0.48, so a 52% reduction in the risk. Here is the overall survival curve. Again, the median not reached, but curves have separated. P-values below 0.05. Not surprising. PSA progression is lower if patients are taking apalutamide. Highly expected. 75% reduction in the risk. Evan was talking about the second progression event with apalutamide in the non-metastatic CRPC, which is an interesting thing. It's the time from randomization until a second progression. Still favors apalutamide in this outcome analysis, which is interesting. I think this is the final study in this cadre. AeraSense is an interesting study in that in this study, everybody got docetaxel for 6 cycles, and we just talked about CHARTED, versus docetaxel followed by darolutamide. Darolutamide, also an oral androgen receptor antagonist, very similar to the other ones in terms of its efficacy from prior studies, maybe a potential advantage with slightly less CNS toxicities. So with this AeraSense study, we're targeting 2 approaches, chemotherapy and the hormonal axis, and we'll see what that study reads out. It'll be coming, we expect, in the next year or 2. I'm going to talk about a couple of new things. I'm talking about checkpoint inhibitors and PARP inhibitors. A lot of excitement in prostate cancer around DNA repair. DNA repair gene alterations are common in metastatic prostate cancer. BRCA2 is the most highly prevalent of these, but it's a minority of the DNA repair alterations because there's so many. And roughly 23% of metastatic CRPC patients will harbor some sort of DNA repair alterations. The interesting thing is treatment-mediated selection pressure occurs, and as we look at later stage disease, we're more likely to see some of these DNA repair alterations. And this underscores the need for us to continue to develop things like cell-free DNA and even metastatic tumor biopsies, because these alterations, if not there in the primary tumor, may be there later. BRCA2 mutation carriers at diagnosis have a worse prognosis. This is Elena Castro's work that was in JCO a few years ago, looking at patients receiving at any point after diagnosis, and quite simply, BRCA2 is a poor prognostic feature. What we'll see is that it's a poor prognostic feature, but it's an excellent predictive feature for good prognosis when you use a PARP inhibitor, and that's kind of the direction this thing is going. So while they have a poor prognosis overall, that flips if you give them a PARP inhibitor, and that seems to be the data that are emerging. So this is the TOPARP-A data. This has been published for a few years now. Won't go into the design, but they ended up looking at biomarker positive, so selecting patients with BRCA2 alterations. And as you can see here, those patients enjoyed a much greater rPFS and overall survival compared to those who got the PARP inhibitor without any BRCA2 alteration being found. And so this just underscores the idea that you're selecting patients based on the molecular profile. There's a phase 3 ongoing study called PROfound, which is olaparib versus AR-targeted therapy in patients with CRPC and previous and known HRR mutations. So this is data that's very fresh, comes from the TOPARP-B study, which is essentially a confirmatory study taking patients with known DNA repair alterations, only selected patients, treating them with single agent olaparib. And you see here in the table, BRCA1, 2, ATM, PALB2, CDK12, or other. And so again, about 44% of all patients will be BRCA1 or 2, consistent here. But if you look down that table, what's really interesting is the rates of response are fairly high when we look at the BRCA2 group of patients, 83%, and a PFS, but a PFS of 8.3 months with the study kind of ongoing. So I think we have still a lot to learn about olaparib and other PARP inhibitors in that setting, but it looks very good in terms of the selection of patients. Here is the study that I find quite interesting, which is Noel Clark's study that was presented at ASCO last year. And this is a study where they took patients and they put them on abiraterone with and without olaparib. Most of them were post-chemotherapy, and these were not selected patients. We could go into this in some detail, but it looks like testosterone, the androgen receptor, do have some sort of DNA repair function. And so when you ablate the effect of androgens in the cancer, you render the cancer transiently sensitive, maybe not even transiently, sensitive to the PARP inhibitor, allowing us to maybe consider these drugs in patients who don't have BRCA1 and BRCA2 mutations. These data look really interesting. Hazard ratio 0.65 for radiographic progression-free survival, but without a survival advantage. So we don't quite know what's going on here, but it's very provocative. There's a phase 3 study that's out to confirm this. I work in the Alliance here in the United States, and we will be launching a similar study looking at both selected and unselected patients to test the concept of PARP inhibitors. So the PROPEL study is the ABI plus olaparib study. Triton-2 is a study that's been presented with rucaparib. This is a study where all patients are selected based on a number, they're listed there, of HRR, or homologous recombination repair genes, a long list, including the common ones, but also some rare ones, and looking at response and duration of response. And this is an interesting study because this study has led to breakthrough designation status for rucaparib in prostate cancer. A phase 3 study called Triton-3 is ongoing, but this study is demonstrating high rates of response that allowed that status to be granted. The bulk of the responses come with regard to rucaparib in the BRCA2 patients. And so what's interesting is if you look at the ATM patients, of which there were only 5, so a little early, but there were 0 responses with ATM and 0 responses with CDK12, most of the responses being in BRCA1 and BRCA2. Now, I do know that with other PARP inhibitors and other settings, ATM patients have responded, so I think it's too early for us to say PARP inhibitors don't work in ATM patients. That's just something we need to keep an eye on. Here's the swimmer's plot for the duration of therapy. What's really gratifying if you're treating patients on one of these trials is that if they have a germline or biallelic loss of BRCA2, these patients can do very well with a PARP inhibitor, and this graph shows that many patients do quite well on therapy for a prolonged period of time. So whether that converts into a survival benefit will be tested in the phase 3 Triton study, which actually has a primary endpoint of radiographic progression-free survival. And it's a 2-to-1 randomization, and the people who are randomized to the control arm get best supportive care. These would be post-abiraterone, post-enzalutamide patients, and they're allowed to cross over. So I think we shouldn't worry about these clinical trials keeping patients away from PARP inhibitors, which is something people worry about, because we now know that there's a reasonable expectation of benefit from a PARP inhibitor such that a patient who is on a control arm should be granted the opportunity to be treated after progression. I'm going to buzz through a couple of other ones. There's a study called Galahad, which is niraparib. That's a different PARP inhibitor. They've taken a slightly different approach looking at biallelic loss of patients with the DDR genes and have shown high rates of objective response. It's a little bit more of a conservative approach in terms of the types of patients that they're bringing in, but again, in particular with the BRCA1 and BRCA2, a high rate of response. And there's a phase 3 plan called Magnitude, which will compare niraparib plus abiraterone to abiraterone alone and mCRPC. So I'm going to close for the last few minutes about immunotherapy. We are probably the one cancer that we get to immunotherapy at the end of our lectures as opposed to at the beginning, because it hasn't really revolutionized prostate cancer like it has some of the other solid tumors. And this is a slide, if you haven't seen it before, is a look at all of the standard cancers and their mutational complexity or mutational burden. So on the far right would be melanoma and squamous cell lung cancer. Bladder cancer, notably. These are highly mutated cancers, and not surprisingly, or maybe a bit surprisingly, these are the cancers that tend to respond to checkpoint inhibition. So prostate cancer is over on the left side here, more or less. It's a disease with a relatively low mutation burden, with one exception, and that is the MSI high story. So about 2 to 3% of patients with prostate cancer will harbor microsatellite unstable disease. Typically, these are associated with alterations in MSH6 and less commonly MSH2. So if you do a sequencing analysis and a test comes back showing an MSH6 mutation and an MSI high status, you want to put that patient on immunotherapy. An anecdote of one of my patients who had been through every treatment, His PSA was 161. He was beginning to have pain. I did this analysis. He was one of the lucky ones, came back MSI high. I put him on pembrolizumab. Within one dose, his PSA went from 160 to 20, 2 doses down to 4, 3 doses to undetectable. He then went on to complete 6 months of pembrolizumab and came off, and that was a year ago, and his PSA is still 0. So, I mean, that's a dramatic anecdote. You don't forget those cases, but if I hadn't sequenced that tumor, that patient wouldn't be here. It's that simple. And this is an FDA-approved drug now for patients with MSI high status. Unfortunately, most patients with prostate cancer aren't fortunate to have MSI high tumors. It would make our jobs a lot more fun, but we do have an opportunity perhaps to test checkpoint inhibition in a broader cohort of patients with prostate cancer. This is the design of the Keynote 199 study, which looks at a cohort of patients with and without prior chemotherapy and measurable disease, and is looking at those who have PD-L1 positive disease versus PD-L1 negative disease, and looking at those outcomes. We have some early results from this study, which is the pembrolizumab in mCRPC, demonstrating essentially a relatively low response proportion overall for the group of patients. So this was demonstrated earlier on with some early studies with smaller numbers, but I don't think we have sufficient evidence based on these results to jump to a PD-L1 a checkpoint inhibitor in an unselected patient who does not have MSI high disease. And so these are the 3 cohorts of that study, demonstrating that the survival is continuing to evolve. The number of events is relatively low, just presented at ASCO GU. So it's possible that a trend might emerge in the enzalutamide combination, which is that cohort 3. I'm just going to go back. Cohort 3, any PD-L1 and bone disease. And so that's something we're waiting on, is the results of the Keynote 199 study. A number of other combinations have been approached. These are the Keynote studies, which you can see combinations with pembrolizumab and olaparib, docetaxel, enzalutamide, and abiraterone. And these are all sort of targeting different facets of the disease where we're going to be using these drugs in different settings. So here, a combination of outcomes from the Keynote 365 study, presented by Evan Yu, looking at the safety of this, but relatively low PSA response proportion. So we're talking about 10 to 12% of patients in here as well. The docetaxel combination, the PSA response is a little bit higher. And what's interesting is what we're seeing here is probably responses to docetaxel, and we don't really know how much the checkpoint inhibition is adding in that setting. And the enzalutamide combination, what we're seeing in this group is a 26% PSA response proportion. There are a number of combinations also being studied. Final moment here to talk about lutetium. We can't really talk about prostate cancer anymore without talking about lutetium, and it's early, very promising data coming out of Australia. This is Mike Hoffman's data demonstrating that patients, many of them heavily pretreated, experience a high rate of PSA response when they receive this radioligand therapy, and this is being tested. Here's the PFS curve, and this is being tested in a randomized trial. The data from Australia are compelling that patients who receive lutetium and have significant PSA declines may enjoy a survival benefit from this. This is not a comparison data. This is data looking at those patients whose PSA declined on lutetium versus those whose PSAs did not decline on lutetium. So this is a single-arm phase 2 study. Lutetium is actually fairly well tolerated. Dry mouth is one of the major toxicities because PSMA is expressed in the salivary glands, and so patients can have difficulties with salivary glands. So these are the trials. The VISION trial in the United States is accruing very rapidly, and it's a best supportive care for post-chemotherapy patients versus lutetium for 6 cycles. There are many options in HSPC based on the extent of disease and a number of patient factors, and new therapies are being driven by molecular subtyping. And I just want to make the point, if you don't do the test, you won't identify those patients. PARP for DDR, pembrolizumab, PD-L1 for MSI high patients. Yes, it's a minority, but the effects can be profound. There are many, many studies, which I went through very quickly, looking at sequences and combinations. So with that, I will stop and catch my breath, and thank you.
This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/NXS860. This activity is supported by educational grants from Clovis Oncology Incorporated, Janssen Biotech Incorporated, Merck & Company Incorporated, and Sanofi Genzyme.